Alrighty, good morning, everybody. Today we have a special guest with us. This is Amy Morris. She is a PT that practices in Pennsylvania. She is also certified in PRI, which is, the science of the physical therapy that we practice here at the clinic. Amy specializes more in kind of chronic conditions, EDS, POTS, dysautonomia, scoliosis, pelvic floor issues, just to rattle off. What was that?
Osteoporosis.
Osteoporosis. So she was gracious enough to let us interview her today, talking about EDS, hypermobility. It is EDS month for the month of May. So we are just going to kind of dive right in and kind of go. And this is all going to be recorded, but if later on, if anybody has questions, leave a comment after this is posted. Amy is fantastic and is letting me kind of pick her brain and ask questions all the time, so we can get those questions answered for you. So good morning. Thank you, Amy. Kind of big thing, tell me a little bit about your clinic. How did you get involved with treating the EDS hypermobility patient group and all that type of stuff?
So the natural progression for me was that I was running an outpatient clinic, and I was known for being really effective treating spines. But there was this small population of people who I couldn't seem to help, and they were the scoliosis people. So I headed down the Schroth route, became certified in Schroth, and took a bunch of classes in SEAS and a couple other scoliosis modalities. And then I noticed that my adults with scoliosis all had osteoporosis and pelvic floor dysfunction. So then I went down those two rabbit holes and took a bunch of classes for those. And then shockingly, they were all also hypermobile and had the pandemic really highlighted all of the other comorbidities, the things that go along. So the people that I started to see around the pandemic they'd always been a little hypermobile. They had some pelvic floor, they had some osteoporosis, but suddenly they couldn't get out of bed because they had POTS, or they were getting really weird rashes, or they had a ton of arrhythmia, or whatever, like they were having all these extras. And that's the thing with hypermobility, is there's all this extra stuff. So I realized that something was definitely going on. I was blessed to get a patient who was hypermobile and a PT.
Okay.
And a form of hypermobility that was severe. Like, she was bedbound most of the time. And she led me to the EDS Society. And then I probably took, 50 hours worth of continuing ed from them in a year. I couldn't stop. I'm a little OCD. So I couldn't stop. And I realized that it's such a unique population that needs to be treated so differently. Also so blessed at the same time as I was going down that rabbit hole, I had started a year or two prior doing all the PRI work. And PRI helped these people in a way that was profound. And I mean, it helps everyone in a way that's profound, in my opinion. But the way that I was able to take the PRI philosophy and help these people find themselves, feel centered, feel grounded, feel their joints without having to use hyperextension. And then that ultimately led to less dysautonomia, a little bit less GI problems, a little bit of less pelvic floor dysfunction, and it just kept going. And I've continued to advance my knowledge on all of those fronts. But in the last 5 years, and everybody will tell you this who works in this world, our patients are getting more sick and more complicated. And so, and I think one of the key points I wanted to drive home when I was speaking at the symposium was that hypermobility falls under the umbrella of a connective tissue disorder. So does Marfan's, so does Stickler syndrome, so do many other things, right? Osteogenesis imperfecta. There's lots of different types of connective tissue disorders. Hypermobility is a symptom. You can have a connective tissue disorder and not be flexible.
Yep.
right? Like you can have a connective tissue disorder that prevents you from having a good filtration system because our connective tissue is part of our immune system.
Mm-hmm.
So you have to figure out what umbrella we're at. If we're just talking about hypermobility, that's a really great conversation, but
Mm-hmm.
it depends on which direction you want to go. And
Exactly.
right, and EDS is one, like there's 13 types, some of them fatal.
Yep.
Right? But the one that's most common is hypermobile EDS.
Mm-hmm.
And you only get to be classified as hypermobile EDS if you hit certain criteria.
Yep.
And unfortunately, many people used to, or they go to a provider that don't know how to diagnose it. So they end up with an HSD diagnosis. It's the same thing. It's on the spectrum.
Yep.
It's just a spectrum.
Yeah.
So
yeah.
Philosophies are very similar. It just depends on, where you come in to the problem. Like, are we dealing with somebody who's just a little too flexible? They're 12 years old. They have a scoliosis. They're really bendy. Then I'm spending time educating on this is what you might see. This is how we can prevent that. Can't tell you how often I have a kid who's, I start seeing them at 8 for scoliosis.
Yep.
Period. And they suddenly start getting POTS episodes, but they're not scared because I told them about it.
Yep.
And then they get a little bit older and I'm seeing them still while they're leaving for college. And then they're drinking and partying and having a good time. And they start having all these other issues. And I'll be like, do you remember what I told you?
Right. Do you remember this conversation we had?
The lifestyle plays a huge role in how we express connective tissue disorders.
Yes. Yes. And that was one of your big things, at the talking about inflammation, all the different things that can cause inflammation, the mold, what we eat, stress, lifestyle. Yeah. Air. I mean,
like I can't imagine the amount of toxicity and inflammation that people who live near wildfires have.
Mm-hmm.
I would be somebody do this study, go figure out how many more people have hypermobility and connective tissue disorders in Southern California after all of these fires that we've been getting. Like that, just the pollution in the air, that will make you more susceptible to things. I just had somebody come in yesterday who is dying from all of the pollen, major GI issues. I'm like, well, they're related.
Yeah.
If your cup runneth over with inflammation, your mast cells are going to get hyperactive and then you end up having major GI stuff. And so let's talk about how we can help you with the inflammation portion of it.
Yes.
And then maybe everything else will start to feel better.
Yeah. It's just crazy. Here, I mean, we're dying of pollen right now.
Yeah.
And Kansas has been doing all these controlled burns. So all the smoke up here, which is great. Love every minute of it.
I don't think that as a culture or a society based on our food and our lifestyle, we don't have resilience. We've lost our resonance and resilience.
Yes.
Right?
Yes, 100%.
Yeah. And so what can we do to bring our resilience back? There's lots of things, right? Yeah. But it's much more of an uphill battle now than it was 40 years ago. Yes.
Well, and especially like you said, after COVID, I mean, it's crazy how life is now pre-COVID, post-COVID.
Well, one of the things that people don't realize is that and it wasn't as popular is not the right word. It wasn't in media, so it wasn't as obvious, is that you had post-viral syndrome. Always. We just have more people with the syndrome.
Yes.
Right. But then these people sat at home for 2 years. And do you think the majority of the people were exercising, eating organic vegan food and taking good care of themselves? Or were they drinking too much, sitting in front of the TV, eating Doritos, right? Like,
yep.
So did we become more resilient or less resilient in that time, irrelevant of the virus?
Yeah.
Like, what did we default to?
Yep. The easy, chill way. It's hard.
That's human nature.
Yeah. So, kind of going on with that, what are some of the other types of things that are seen with people with hypermobility EDS. You kind of mentioned GI issues, and there's some of the compression syndromes. Like, can you talk a little bit about those, of different signs, symptoms that people might see that they don't realize that, hey, this could be related to hypermobility?
Sure. So I'll back up and I'll say, I'm going to talk about connective tissue as opposed to hypermobility.
Yep.
Just to clarify. So connective tissue is in everything and does everything. Our nails, our bones, everything, right?
Yep.
So depending on if you have a genetic issue where a type of collagen or connective tissue has a dysfunction to it, the function of everything that has that type of collagen in it will be impacted. How much it's impacted is, or expressed, how it is expressed, is often dependent on lifestyle. Just like heart disease, right? You can have a family history of heart disease, and do you express that trait?
Yes.
So I always, whenever I do an assessment of somebody, if I see that they have 3 or more systems that have significant issues, and I'll explain what that means, my spidey sense goes off of like, okay, there's a connective tissue issue here. So for example, I have somebody who came to me in her late 40s who already had a retinal detachment, had mitral valve prolapse, had varicose veins, and bruised really easy. She was super tight everywhere.
Sure.
Hypermobile.
Yep.
Had pelvic floor issues. And I'm like, okay. Right. Oh, I'm sorry. And her scars had keloids.
Okay.
Which often follows a certain skin type, but her skin type is not one that would typically get keloidal, which is the thickening of the scars.
Yep.
So you take all of those things and I'm like, okay, well, there's definitely a connective tissue issue here. And we got to the debate of, but I'm not flexible. And, that took 3 or 4 sessions and lots of education. Right. So that's where I'm always assessing, like, where can it be a connective tissue issue? Right. Do you have issues with tissues, as I always say? But then if you think about all the different systems, the system that is most impacted besides musculoskeletal would probably, I would say second would probably be GI, although nervous system is a close second. And then there's cardiovascular. I can just keep going if you have certain types of connective tissue issues. But the GI system, I had presented that 84% of people with hypermobility have GI problems.
Yeah.
So if you reverse that, right, how many people with GI problems have connective tissue disorder that's been undiagnosed? Right. So anybody who has a megacolon, right? Anybody have their gastroenterologist tell them they have a megacolon? It's probably a connective tissue disorder.
Yeah.
The things that we see that are typical in the GI system would be reflux that's not really controllable. Anybody who comes into your office and says that they've been on reflux medication for 3 years, that should set off your alarms.
Sure.
Well, it's terrible for you. And second of all, that should be something that's addressed.
Yeah.
Chronic constipation, dumping syndrome, which is when we have like you eat and then you immediately have diarrhea. That's another one. There's a lot of GI things, diverticulosis, diverticulitis, GI bleeds, spontaneous GI bleeds. Those are all signs that there's something going on. And then you mentioned compression syndromes.
Yeah.
So abdominal compression syndromes are median arcuate ligament syndrome, superior mesenteric artery syndrome, nutcracker or renal vein compression, and May-Turner. Okay, so those are the 4, and they're all abdominal compression syndromes, and they go together. If you have a connective tissue disorder, you are very likely to have more than one. And the first 2 I mentioned, which are superior mesenteric artery and median arcuate ligament syndrome, are very much triggered by faulty respiratory dynamics, which is why PRI is amazing, as we work so much on the diaphragm, right? Like you can have genetic predisposition, and then you can create the drama through inflammation and faulty respiration and alignment and posture.
Yeah.
Symptoms from that is typically pain and nausea with eating, pain right below the xiphoid or the solar plexus in your stomach, vomiting. Sometimes it's diarrhea. You can Google all the different symptoms.
Yeah.
And then the other two compression syndromes are more associated with pain, usually on the left, in the back or the belly or the pelvis, and sometimes swelling in the left leg, not the right. Well, that's not true. If it's severe in advance, you can get swelling in both legs, but it typically starts just with left. So if you've got left-sided varicose veins, left leg intermittent swelling, especially with your menstrual cycle, if you're a woman, that could be a sign that you have the beginnings of May Turner, which is a compression syndrome.
Gotcha. I don't think I realized that with the menstrual cycle.
Yeah, I feel, well, that's been, okay, so that's my clinical experience, is that when we are menstruating, right, we tend to get more pelvic pressure, pelvic congestion. Our GI system changes. Hormones affect our bowel and bladder, right?
Yeah.
Mostly bowel. So if we get a little more constipated, everything gets a little more crowded. And then we can have more of that left low back, left lower extremity symptoms.
Sure. Oh, interesting. How, you kind of talked about how PRI helps with like the breathing, and the positioning, the posture, all of that type of stuff. How else have you seen PRI help this patient population?
Definitely PRI has helped people the somatic portion of PRI, helping people to feel where they are in their body.
Yeah.
Has been, I think, life-changing for some people. For me, like like me personally, I can feel myself more, right?
Sure.
You can feel your weight going back and through your heel and get your rib cage down. And I mean, in times of great stress, I'm the first one to flare my ribs and go right and do all of the things we are not supposed to do. And
right.
You're like, okay, I need to go walk up the stairs backwards, and I need to practice how I'm standing, and I need to, do some breathing exercises. Yeah. So there's I think one of the best parts about PRI for me, and I think for my patients, is it gives people really specific actionable items to feel different.
Yes.
Right. Like going and doing a set of 10 squats might make you sore, but I don't think you feel different in your body. Well, maybe if you do it really great and patterning, but you know my point, right? And we're all seeking, I always feel like people are always seeking greater ability to feel joy in their body. Safety first, then joy, right? And even if it's subconscious, if we don't feel safe because we have these hypermobile tissues, or we have lack of stability, or we have poor motor planning, we're not going to have a lot of safety, and then we get autonomically driven. More anxiety with this population, a lot more anxiety with connective tissue disorders. And so PRI has helped me help people feel more stable in their bodies, and that has a ripple effect.
Sure. With the PRI and just treating this patient population, we have to go slow. We know that. How often do you typically see these people? Traditional PT, has always been 2 to 3 times a week, all that type of stuff, but as, let's say, somebody brand new is coming into your office, what would you say, because we get asked this question all the time, but what would you say is like a typical time frame of how often you see them? How everybody always wants to, how long am I going to be in PT? We're always like, well, this is like a lifelong thing. So it'll vary as you get more stable, feel yourself. Like sometimes we got to start more at the beginning and then we start to taper off. But what's kind of your experience with this patient population?
Well, Couple things. I usually say to people, if you have a peanut allergy, how long should you avoid eating peanuts?
Right.
Right. So we're always going to have to manage this condition.
Yes.
Right. It's a condition. Just like if you get a sunburn every time you go outside, you have to wear sunscreen. Right.
Mm-hmm.
It sucks, but it is what it is. Everybody has something. And it's how often I see people is based on a couple of things. First, how far away do they live? Because I have people who sometimes drive like 3 or 4 hours. So
Sure.
I'll see them every 6 weeks in person, and then twice a month on Zoom. And when they come in person, they'll stay overnight, and I'll see them 2 days in a row.
Sure.
So that's one demo.
Mm-hmm.
Then I've got the person who is very frail.
Mm-hmm.
And they need to start very, very slow. And they need a lot more coaching because they have poor body awareness, and they're probably not going to do what they need to do at home. Those are the people I say, I need to see you for 8 to 10 visits, 1 to 2 times a week.
Yep.
And that is very slow,
Mm-hmm.
very, very slow and gentle. And then we wean it down.
Yeah.
The average person that comes in that has the fortitude to do what they need to do, and the cognitive ability to do what they need to do, and have the resources to do it, I would say once a week for 4 to 6 weeks,
Mm-hmm.
if you do your homework, which is, I try not to give too much. And then
Right.
I say, I would like to see you once a month for the rest of your life. Because it is a condition that needs to be managed. And sometimes I say every 6 to 8 weeks, depending on like who they are. If they're, if they're 23 and they're, in a graduate, they're in med school, I know I'm seeing them 4 times a year because they're busy.
Right.
Just like if you have a thyroid problem, you have an endocrinologist, right? You go to your dentist. I think that I like to be the lifetime practitioner, and there are people I see 4 times a year, and that's great.
Yeah.
I always come in with their list when I see them. Right.
Yep.
But I have people I've been seeing for 10 or 11 years, and I just see them.
Yep.
So, and I think to answer your other question of how long? Mm-hmm. In my opinion, with a hypermobility diagnosis, it depends on how deeply ingrained your patterns are. The older you go, the harder it is to break them.
Sure.
Right. The more compliant you are with your exercises, the better.
Yep.
More likely you'll be able to break those patterns.
Yeah.
So it's very variable, but I usually say by visits 4 to 6, if you're not feeling something different, then we need to change strategy.
Yeah.
Just something. And maybe that something different is a whole new pain.
Sure.
Right. Like, my right knee pain is gone, but I have this weird pain in my left shoulder blade. And I'm like, oh, that's awesome.
Yeah. And they're like, what? Like, what the heck? It's like, no, it's something new. Like this is.
And we've made a change. Now let's figure out what are we chasing?
Yes.
What layer have we peeled?
Yes. Yes. For this patient population, who are like the other team members, because this is a multidisciplinary approach. It's not just one versus the other. We were chatting earlier here in Nebraska, hard to find providers. Like we just don't have the massive amount of providers like you in Pennsylvania, being closer to New York, Boston, Philly, all that type of stuff. But who are the type of providers that these patients should be looking for to have on their healthcare team?
Well, obviously PRI is awesome, and they have the optician and the dentist.
Yep. Right. We have those guys here for us.
I won't go down that rabbit hole, but that I think is a really great thing.
Yes.
Having a functional medicine person, because I don't think traditional medicine gets the whole inflammation concept, mast cell activation, all the like you go to a GI doctor and they're like this, okay, I see your colon, right?
Mm-hmm.
You get an endocrinologist and they're focused on your endocrine system, right? Gynecologist only looks at your pelvis, right? And nobody's looking at the whole you.
Yeah, the big picture.
Mm-hmm. So getting a good quality functional medicine person who knows how to screen you for inflammatory factors, metals, mold, infections, all of that, get all of that cleaned up and help you with your lifestyle.
Mm-hmm.
That would be the number one thing that I would say. And dental and vision.
Yeah.
I have a person who does body work that's local, Just because you're hypermobile doesn't mean you can't have somebody working on sore muscles. That's
Sure.
not a bad plan. If that's something that you feel like you need, as long as they're not stretching you and working too deep, because that can be wrong. I have, having a really good GI doctor would be amazing. Someone who's going to test you for SIBO, right? Because SIBO is triggered, small intestinal bacterial overgrowth, is something that is often triggered by reduced motility. Reduced motility is part of hypermobility, right? So having
go hand in hand.
Having a really good GI doctor, a good gynecologist that's going to be able to help you figure out if you have any kind of prolapse or cystoceles or ectoceles. Those are all great things. A pelvic floor therapist.
Yeah.
I mean, I got so overwhelmed that we have a pelvic floor therapist who's amazing with pelvic floor and hypermobility on staff here. So that's been really, really helpful for the men and women.
Sure. Is it a pelvic floor therapist that does more of like the internal work, more, because we, PRI, we take like the outside in approach, make sure you have the stability of your pelvis, all that type of stuff. But are some of these people, are they needing more internal type work to help them out, or
so
what have you seen?
It's we just had this conversation last week. This is why I'm chuckling. The woman who works here, she does internal. She has a very similar philosophy. She's trained in PRI. That she always does an assessment in the beginning to know where we're at and to make sure there's no prolapse.
Gotcha.
So often with hypermobility, the organs that are held up by the connective tissue in our abdomen and pelvis are sagging down.
Yeah.
If your bladder is coming out your vagina, no amount of PRI is going to fix that.
Exactly.
Right. Can you help it by changing your pressure regulation and how you breathe and how your muscle support? Absolutely. There's ways to help that, but it's not going to change it. And having external support through a pessary or something else might really change the trajectory of whether you're going to need to have surgery. So we want to evaluate that with this population as early as possible. So we can stop that progression if we can. And then she typically doesn't do internal unless needed, unless she's reassessing, because she finds the PRI work does a lot of what needs to be done. An exception to that rule is, like, we have a patient with MS who has spasticity. So she's hypermobile and has MS. Right. Which, by the way, you can have two things. Her doctors argue with her, but you can actually have two things. You can have MS and hypermobility. Everything is due to her MS. Right. And right. So you can have two different things going on at the same time, which is it's so funny. Once you have a diagnosis, everybody wants to attribute everything to that. Like
everything to one thing.
Just because you're hypermobile doesn't mean you can't get MS or something else. Like, once you get that label of hypermobility or EDS, then everybody wants to say, well, it's due to that. The curious person who goes, well, yeah, we know we have that, but let's see. Can you also?
What else could be going on? Yeah. And it's like you said, we've had so many advancements in the medical field. Like, it's great, but everybody wants to be a specialist. So we're looking at this tiny, tiny, tiny little hole, and
we're a whole human.
And it's just these patients, they come in, and I feel like PRI is great because we look at the whole system. But I think most of us that have been practicing PRI, we just listen to them. They just want to be heard. A lot of the times, just with them telling us stuff, it's like, oh yeah, light bulb moment. Like, you're not crazy.
So many patients come in with a stack of papers and everything, and they're apologizing. And I'm like, why are you apologizing? How can I help you if I don't know everything? I do ask if I can get it in advance so I can be more prepared.
Right.
And I can use your time with you for you rather than reading your tests. But no, we love that. And again, we love that. And now we know what's going on. Now let's stop focusing on your disability and help you find your ability.
Exactly.
Like we don't
Exactly.
want to spend all our time focusing on the fact that you broke your ankle when you were 7 and now you're 52. I get
Right.
it, right?
Yeah.
Like that's a contributing factor. It's
Yeah.
in here, but now let's figure out how to get you better biomechanics.
Yeah. How much time do you spend, there? I feel like, I don't know, like I've been out of PT school 13 years now. I'm a baby in the PT world. I get it. But, pain science was getting their huge moment kind of when I was graduating, Lorimer Mosley, David Butler, all those guys, Louis Puntadera. How much time do you spend on, that type of education? Because I feel like when you're reading stuff on hypermobility, connective tissue, everybody's like, oh, pain science, like you got to talk about it. And
Well, faultyception, right?
yes,
You can say per intero, extra, like perception of
yeah,
internal, external world is altered, right? I'm
mm-hmm.
a person who, if I get a paper cut, I want a narcotic. I have big feels, right? My
Right.
husband could literally fracture a bone and be like, huh, like, okay, I get a cold and I just motor through. He's down for the count, right? Like we're
Right.
different. We're all so special and unique, right? And
Yes.
knowing ourselves is great. That's the beauty of age, is we get to know ourselves.
Yes.
But pain science, there's the feedback loop, right?
Mm-hmm.
The more you focus on it, the more you feel it.
Yeah.
So this is not meant to be flippant. I never mean to sound flippant. I say this to my patients quite regularly. Pain is inevitable. Suffering is optional.
Yep.
Right?
Yeah.
Me personally, it's rare that I don't experience pain in a day.
Yep.
It's usually like a 2 or a 3, but like, I'm hypermobile. I'm always like, oh, what was that? Oh, there goes something again, right? Like, or I have such a headache or whatever it is.
Yeah.
It's having respect for the pain,
Mm-hmm.
telling the patients that, like I always say that, so my pain scale is 0, none, 1, 2 aware, 3, 4, 1, 2 aware, 3, 4 annoyed.
Yep.
5, 6, you can't focus. Like you could not work if you were a 5, 6. 7, you're on the way to the ER. 9, 10, you'd rather be dead. Okay, like it's just severe.
I like that pain scale.
I think it's really clear, right? I'm like,
yeah.
Can you not focus because of this pain? Is this pain really distracting you? Or are you just annoyed? Like, and I do the same thing with the scale of effort with people when they're doing an exercise. Mm-hmm. I want this to be, when you do something, I want it to be unpleasant. I don't want it to be painful. Like if I'm trying to get your left posterior hip capsule to open, if I take you to a 7, 8, where you're like, oh my God, this is excruciating, your body's just going to rebound and you're never going to hold on to that change.
Sure.
Right? I need you to be there and breathe. So I do the same thing with them when I'm talking about pain. Where are you in your pain? Mm-hmm. 8 out of 10, and really an 8 out of 10, not what they're saying. If you're really in severe pain, we need to manage that before we can do anything else.
Yeah.
Right. Yeah. But so often people are saying they're an 8 out of 10 and they're like cracking jokes and having a good time while you're working with them. So we all know as PTs what we have to do. Get them focused off of it and help them figure a way to work through it. And so often stability and strength reduces pain.
Yes.
And giving them different input reduces pain.
Yeah.
If they can feel something different, then the chatter of the pain gets better. Mm-hmm. And anybody who works with people in pain know that.
Yeah.
But people can be validated, right? Like if you just keep brushing off their pain, that's a problem.
Sure. So kind of piggybacking off of that, everybody wants to like be diagnosed, or really have I don't even say have the label, but have validation. Like, yes, like I have EDS, I have hypermobility, all this type of stuff. And, the hypermobility EDS is just meeting a certain criteria. There's currently no genetic testing for it. When would you recommend for people to get that actual diagnosis, to go get tested, that type of stuff, versus not, and just knowing that, hey, yes, you are hypermobile, you're on the spectrum of hypermobility. And why would you say, yes, go get tested versus not? And how can that impact different things in their life that they might not even think about, in disability insurance, all of these other things, because I think everybody just wants to know, yes, I have this. I can tell my doctor I have it, but it might not be the most beneficial thing for them long term. So what's kind of your input on that?
I'll never forget having a guy come to me whose wife was pregnant. He was in his 40s. And when he was in his 30s, he had a small bout of depression, was medicated for 3 months, and now can't get life insurance. Oh my gosh. Yeah. So 15 years later, it's on his record and he can't get rid of it. Right?
Frustrating.
So to all my patients who want a diagnosis is, I validate you. I think you're hypermobile.
Sure.
If you want to go and get genetic testing to rule out the scary stuff, I would do it. I'd privately pay for it.
Yeah.
Right? I wouldn't want it in my health record that anybody else could look at. I know that costs more, but something to think about. And again, depending on how disabled you are, if you're disabled and can't work, then it's probably less of an issue for you to protect your diagnostics. Yeah. But when I have a 14-year-old kid in here who's really hypermobile and mom is gung-ho to get her an EDS diagnosis, I'm like, hold off. Times when I push for it is if I think that there's a vascular component.
Yeah.
You definitely want to rule out vascular. And the other thing is something people don't realize when they have connective tissue issues. We'll go back to connective tissue rather than hypermobile.
Sure. People
with connective tissue disorders process and utilize pain medication and all medication different. There's this myth that is actually a fact. Okay, I'm not going to say a fact because I don't have anything to back it up, but it is well known that redheads do not do great with anesthesia.
Yeah.
Right? Well, guess what? Neither do hypermobile people. I need 12 shots of Novocaine, which then has epinephrine in it. So then I'm getting racing heart. Dental work for me is terrible.
Yeah.
And nobody believed me.
Yeah.
I went through a childhood of excruciating dental issues because nobody believed me when I said I wasn't numb. Right. I have a patient who just woke up in the middle of a colonoscopy.
Oh, geez.
She doesn't process. Right.
Yeah.
So you don't have to be like, hey, I have hypermobility. If you know that you don't process pain medication well, pay attention to your body. I would much rather have an Advil than a Dilaudid. Advil works so much better for me.
Yeah.
Well, these are things we have to learn about ourselves. If you have weird scarring, you may have trouble healing when you have an incision. Yeah. And that's if you're pregnant, you want to know that in case you need a C-section.
C-section, yeah.
You don't have to have your diagnosis to say to your doctor, do you have experience? And if I have a C-section, you need to sew me up in multiple layers and probably use glue. And we need to be a little more careful in post-op and make sure I don't tear.
Yep.
Right. Knee replacements, same thing. I've seen some blow up, and I don't mean infections. People get their knees replaced and they have a connective tissue disorder, and the connective tissue is not holding the knee where it needs to be. Yeah. And the knee is sloshing around, and it's well, it wasn't the joint that was the problem.
Exactly. And then the doctors are like, your knee is fine.
Yeah, exactly.
Yeah, exactly. No, it's not
fine. Those are all things that I would say, do you need a diagnosis or do you need to be an advocate?
Sure.
If there's a vascular component, or you suspect that, if you have more than one ancestor that died of unknown causes, or an aneurysm.
Yeah.
I'd be getting checked.
Right.
That's, people who are dropping dead of weird stuff, and there's a way to know, because that's stuff that you can monitor and prevent something tragic.
Yeah. And I know, if people that are watching, that you're like, oh, some of these things are starting to ring a bell. I know on the EDS Society page,
Yes.
they have kind of like a checklist thing. So you can look at all the different,
They're great.
the 13 different types of classifications of EDS, and it can go through symptom by symptom, like body part, like you might have this, you might have that. So that's a good way for people to see, like, oh, like I didn't realize that this could potentially mean something. But that is a great resource.
I send everybody there.
Yeah, I mean, it is fantastic. Even as a provider, there's the app and everything to do some of like the Baton scale, all that type of stuff. I'm
gonna hop in there. Baton scale, not super accurate.
No, not super accurate.
When your doctor says, if you can't touch the floor or do this with your thumb, you're not hypermobile, or you don't have a connective tissue disorder, find a new doctor.
Exactly. 100%. But that's unfortunately what they use right now, with a couple other things.
Old school docs, they learned it when they were in med school, and they're not keeping up with what they need to know.
Yeah.
Right? The continuing requirements are not very high.
Yeah. Yeah. Have you seen a shift at all in, and I don't even know if you know this, of what they're being taught in med school regarding mobility or anything? Okay. Just, I know some of the world is shifting a little bit more with like the menopause, perimenopause, like it's finally having its movement and all that type of stuff. So I just didn't know.
But that's because of people like you and the rest of the world who are being
demanding answers.
And also putting out podcasts and doing it. Like, I'm sure, like, I love when people come in and they say that I listened to this and what do you think? Like, I'm like, I love when people come in educated.
Yes, 100%. 100%. Well, Amy, is there any other things that you would like to let kind of the world know about connective tissue? And
I think that just understanding that you can, a couple bullet points, you can have connective tissue disorder and not be flexible. Right? The connective tissue does everything. So go to the website. You don't have to remember everything I said, but go to the EDS website or come to my website, or, there's information out there.
Yeah.
Advocate for yourself, because your doctors don't know. Your doctors do not know anything about connective tissue. And what they do know, you need to be your own best advocate for everything, but specifically for this. And that you're not crazy.
Yeah.
Maybe crazy, but not because you have connective tissue disorder. It's connective tissue disorders are closely linked with anxiety and depression. Who wouldn't be anxious and depressed if nobody believed them?
Yeah.
Right? Like, I have the box of tissues here because when people sit down and they start telling me everything and I go, well, you probably have median arcuate ligament syndrome, and that's why you can't eat.
Yeah.
I have what? I've been to like 7 GI doctors. I'm like, okay, but has anybody touched you?
Yeah.
Right? Yeah, they'll do a colonoscopy, but have they actually touched you? So just being a really good advocate, right? And find resources. And it's so easy for a specialist to be overly confident. They're like, oh yeah, you're fine. But you really want to find people who hear you, listen to you, and process what you say.
Yeah, 100%, and a lot of times, unfortunately, sometimes you have to go through multiple providers.
Well, and I heard somebody say this not too long ago, and it made me so angry, like that Ehlers-Danlos or hypermobility is the diagnosis du jour. Well, I remember, I'm old. I've been a PT for 33 years, I think, 32, 33, something like that.
Yeah.
10 years ago, 15 years ago. Okay, I'll say 15, 20. Celiac disease that's not a real thing.
Yep.
And And anybody who avoided gluten was just being high maintenance. Not so much anymore.
Yeah.
We are, as a society, so much more inflamed.
Yes.
And we're all getting so much sicker. So then we can go down the rabbit hole of our food sources and everything else. But so it's not the diagnosis du jour. It's just the fact that people cannot, they can't find homeostasis. We're not resilient. We don't have the ability to find homeostasis. So kids are being born sicker. They're getting diagnosed younger. And a lot of it has to do with your health when you get pregnant. And pass on to our kids. It's overwhelming.
Yeah.
So, no, you're not crazy. There's definitely a major shift in the health of our country.
Sure. All right. Well, thank you so much. I don't want this to take too long for people. You know, we like keeping things a little short and sweet because we get it. People are busy, but we will have this posted on our YouTube page. I think we're going to put it on our webpage as well. And Amy will put the link to your clinic, which is Ahimsa Therapeutics, if I remember correctly.
Ahimsa.com.
And we'll have that there. And again, if people want to ask questions, post comments, all that type of stuff, if they have anything directly for Amy, like I will reach out to Amy. And we appreciate it so much. And we are so happy that we have you as a resource to help us learn and dive into this world even more.
Absolutely. Help more people. And letting me spread the word.
Sure. Thank you. Have a great day, Amy.
You too.